Well, good morning. I'm Stacey Whanger. I'm the manager of our West Virginia Practice-Based Research Network, and that's the topic of the discussion today. We have Dr. Bill Lewis. He is also going to be presenting from Harvest Ferry Family Medicine of the Eastern Division. And then Dr. Mary Leclue and Dr. Drea Haggerty are going to be joining us here towards the end to have a little bit of discussion at the end. We are going to go over a couple of things today on the agenda. We're going to get just a brief overview of the network itself, talk about how to engage with the network in research. We also provide some project support as a network, and we'll go over some of that as well. We're going to finish off with the current research that we're working with in clinical and translational science, and then talk about how that has had an effect on primary care so far. So what is a PBRN? The PBRN is a network of healthcare providers, clinical administrators, and researchers that are all coming together to work on research as a group. And so what we really want to do is provide a network to support that. So one of the ways that the network functions is really to build up those relationships with all of the network partners. So they come from a lot of different backgrounds and they have a lot of different goals, and so we want to make sure that their expertise is all included into project design. We also want to work to translate that research back to primary care. So there's an immediate or almost immediate benefit back into clinical practice. And we want to make sure that we're providing networking opportunities. So not only within the network itself, but also to find other ways to collaborate with communities, health departments, other research institutions, other types of specialty providers. We want to make sure that we can get a large group together to work on whatever project that we need. So here in West Virginia, we have established the first and only PBRN, and that was established back in 2013, right after the West Virginia Clinical and Translational Science Institute received. We are part of the CTSI and fall under the Community Engagement and Outreach Corps. And so back in 2013 is when we first got the group together to talk about whether this is something that we can see being viable in the state and what kind of infrastructure and goals that we would want to set out for ourselves. So we started with 30 clinics, and now in 2019 we have 95 individual clinics in West Virginia. So 71 of those are federally qualified health centers. So that makes up the biggest proportion of our membership, but we have 20 sites that are academic-based, we have 2 rural health sites, and then 2 critical access hospitals as well. So the goals that we established early on, we really tried to secure as the framework for our network to move forward. So the first one is to start and establish these partnerships across the state. So we've done that in a lot of different ways to focus on West Virginia health. We collaborate on many of the CTSI projects. We have our yearly retreats, so we have our internal networking that we do. So we want those partnerships to foster over time. We've also wanted to strengthen the capacity to do research in West Virginia. So a lot of our sites are very new to research, or some of them don't have a great deal of experience in research. And so what we want to do is extend that resource out to them so they can not only participate in research and be good research partners, but eventually conduct their own research. And we want to go back to translating that research back into clinical practice. That's really important for the clinicians to see that after they participated in research, what kind of benefit they see that can go back to their site and their patient population. So to engage with the network, there's a couple of ways that are good strategies to make sure that that partnership is going to be really successful in the end. So the first thing is really to establish what the clinical and patient care aspect is in the study itself. So how is that going to relate back to the clinical practice and patients? It's important to make sure that that's clearly stated, because sometimes it's not as obvious to the researchers or the primary care where that balance is. That's something that we talk about to make sure that we get all of those entities covered. We also want to provide input from all of these places to make sure that everybody's voice is heard into the project, and so then everyone is happy with the success as it moves forward. And then we also want to create that dissemination plan, so we know exactly when we get the results where they're going and how they should be disseminated to. Those things change as project changes, but we want to make sure we have a solid plan in place ahead of time so we know what those goals are at the end. We seek input from our network providers for have them be able to share information about everyday practice. They're the ones that are seeing patients, and they know their patients best. So if we can get their clinical expertise into the project, it's usually more successful. And then we also want to establish what this beneficial partnership is going to look like mutually. So we want to know what the primary care providers can have a role and what kind of impact they can make on the project itself. But we also want to know what kind of information the researchers can bring back to the primary care. So we want to make sure that it's balanced. So for a lot of grants that have funding, we have usually some way that we can share some of the funding with the sites. Usually that's for time, because anytime we're doing research, there's time from the clinic that's spent on the research project and may not be seeing patients. So we want to make sure that we make it so they're not losing any money by not seeing patients. But that's not the only way that you can interact with the network. You can also provide access and support to other resources available. That's usually for primary care. A good one is specialty care. That's really hard to come by in our state. So if there's a way to reach out and get specialty care or new technologies or things that might be beneficial and just not available in some of our rural sites, that's important. And then increase knowledge for new techniques, best practices, things that we could share with our sites that are so busy they can't always take time to look into. We can provide all of that to them as a way to compensate the time that they're giving the project itself to participate in. And then we also want to make sure that the dissemination is shared broadly as well. So we obviously want to take back that information to the clinical site, but how we would disseminate to a clinical provider versus their administrator might be very different. They're going to be looking for different things. If the patients are involved, then they're going to be looking for a whole new set of things. We want to make sure that we're disseminating in multiple ways and reaching the populations that we want. So to get to the point where the PBRN becomes involved, we have a standardized process, which is pretty simple to navigate through, but we created a protocol review process. And that involves a committee that we have put together that involves clinicians, clinical administrators, researchers, and some general community perspectives as well. But we really want to make sure that the project is a good fit for the network itself. And we want to be good partners. We want to make sure that that works. So what we generally recommend to work with the network is to set up a consultation first with the network staff. And so what we do is just provide some general feedback into what we think might be helpful to make that partnership work. We can give that information ahead of time. Here in Morgantown, myself and our coordinator, Angie DeWitt, is here to meet for consultation. And then Bill is out at Harversbury, but we connect with him electronically often. And our other co-director is Jennifer Boyd, and she is at New River Health Association, the PA. And so they're always available to field questions and reach out to provide that consultation support. So once we get to the point where the project is ready to be reviewed by our committee will look to see that the project is feasible in a clinical setting, depending on what the project needs. Is it something that a clinic can actually perform and do well at? If not, they'll provide feedback, but generally they just want to know is it something that they've got the ability to do. And then also look at the relevance. So with all the health concerns that are in West Virginia, we sort of identified these priority areas that we really want to focus on. We want to see if those projects fall in that focus area. And if not, then what is the impact that we're making, and why does that project need to be bumped up to the top? So they really look at all of that and determine how that fit is going to work. And then with their recommendations, Angie and I can circle back and see if there's changes or suggestions that we can make to the project itself before we get going and move forward with it. So once the project is accepted by our protocol review committee, there's a lot of other support that the network can provide to the project. So as we mentioned before, the study design is a big factor that we can participate in and help make the project a success. That happens in the protocol review committee and with all that feedback that they provide, but it can go the full length of the project. So we can always reach out to our providers to have phone calls, focus groups. We can reach out to folks individually based on the strengths that we know of our network. We know certain providers and certain clinical staff have particular interests and goals in mind, and so we can reach out to those to get specific feedback. We help with recruitment, so sometimes that's recruiting clinics themselves. We provide the recruitment for providers as well, and then we also help them recruit patients. So that's something that is involved in the project itself, and we can work out what's the best recruitment strategy for our providers and membership. Another place where we're helpful is helping the clinic themselves actually implement the project. So as I mentioned, there's a lot of the sites that are still relatively new to research, so there's certain research aspects that they may not be familiar with, might need help just getting going and continuing the process. So we're there to really support them, to make them good research partners too. So we like our role of being that middle person, so we can really support both sides of the research, and also be able to be there on hand if they run into issues. We can help them through those. And then lastly, back to the translation. This is such a key piece in what we do, translating and disseminating back out to those providers, so then they know the research that they participated in, they know what that impact was, and they know that they can share the information back to the patient to be proud of what they've done. So I'm going to turn over to Phil, and then we'll talk here at the end.
Thank you, Stacey. Stacey kind of gave a rundown on what we like and how we run more traditional projects and everything. We've got more ways for researchers to kind of interact with the PBRN beyond that. The first one is a new one that we've started. It's called the School Survey. We kind of formed off of the CIRA survey model. Anybody know CIRA? It's really common in primary care. They submit a series of questions and they go out and ask program directors, and then you can submit a series of questions for deans of medical schools. You can have one for PBRN directors. Nobody was doing this in PBRNs. One thing we're always really cognizant of is not to overload our clinics with too much questions, surveys, data, all this kind of stuff. So we don't want to burn them out. We want them to be active participants. So we get requests for surveys fairly frequently, and we've molded it down to the CIRA format. So every November we call for submissions. People send us a series of 10 research questions. We put them together and then send them out to the PDR membership to get physicians' feedback on. We select the top 3 groups of questions. So this is our second year. Our first year we got 5 submissions from researchers. This year we got 10. It's a great way to get pilot data, to start a project and everything, and get feedback from across the state. And it's really nice that we're not bugging our clinicians all the time for this survey and that survey. So next November, if anybody's interested, there will be another round of questions. We do ask if you do it, you get a comment, you give a presentation, present your questions to the group. We like to get our feedback to everybody. The other one that everyone's invited to is we have an annual PDR Retreat. We try to get our researchers and partners and clinicians from across the state together every year in Stonewall. This year's in May, 16th and 17th, I can't remember these things. But we're getting together then, and it's a really good networking opportunity. In addition to the networking and getting together, we disseminate the results every year. We have a poster session, 10 to 15 posters, usually kind of across the board. Everybody can talk and share what they've done. And we try to do some brainstorming on what really our priorities are, what's important for research across West Virginia, what's important for primary care physicians and clinicians across West Virginia. So 2 years ago, we did our brainstorming on what really is vital and what needs work. we're not talking about anything that's really shocking here. Substance abuse comes up time and time again as a priority area, and that was what came up for us. And it's not just that, it's the prevention, the treatment, what you do on policy levels. And then chronic diseases, of course, most people term it diabetes, but all chronic diseases kind of fit in when we're talking about it. And then really important that came out of those two top ones were the social determinants of health, what led to some of these chronic diseases, and this can go into transportation, different things. We've taken these, from the PBRN leadership, trying to recruit projects, trying to build it. This is our framework for what we're looking for. So across the years, this is what all we've done in the past 2 years that tie back in really to the problem areas that we want for our members. So the echo is always there. We've got MAT expansion, opiate projects. We've done core surveys on opiates. This is even putting in helping with heal that's hopefully being improved. This hopefully getting
Right. Yes.
And then chronic disease, we've had on opiate back pain treatment, more surveys, got a new echo on chronic lung disease, we got echo, we didn't even include the echo on endocrine treatments. That is starting out very well. We've got the cognitive depression core funding, that is coming down very soon. More weight management, and again, we've done more on social determinants of health. The IRIS project, I'll talk about it more, but we were getting more of the ability out into the clinics to screen for diabetic retinopathy, not just having to go to the ophthalmologist. So we try to take our feedback, and so if you can come to the meeting, it gives a chance to kind of interact and talk with everybody and really formulate the ideas that we are doing. And we try to take what we have seriously and try to build off of that. So far, we've had 25 projects since 2013 we've completed, and we've got 27 ongoing projects across the network and another 25 getting ready to get submitted and started. So we're busy, so I will make a plea. If you want to engage in a project, talk to Stacey early on in the process. She's very busy now, and we're moving along that. We've had good luck with funding, especially participating in the 40 projects. So we're doing there very well in the external funding. We've had 13 projects get funded through CTSI. Making progress and really helped us change the numbers. So better than last year. So what do we track? When you're looking at a practice-based research network, again, we want to make meaningful influence on our practices, the people who we work with. So we look at actual practice changes. We did a KPEC project earlier that was looking at how we manage chronic disease. So what changes did the clinic make that they kept from it? The IRIS scan, we've got the IRIS scan. So far we've got 60 tracked changes across the 40 projects that we've done. We've moved on, and then we look at policy changes to see at a bigger level. The IRIS scan, we've got 4 different payers to now pay for the IRIS scan technology. Before that, they weren't paying for remote retinal scans. You could only get it paid for if you went to the ophthalmologist. So Stacey went out and talked to the insurance companies and showed them good data, and we were able to move that forward. And then finally, the systems changes is the other one we track. And these are where we can help other people. So it helps found the Greenbrier County Regional Health Alliance and got them set up to get tax exempt status and everything and become more functional. So, beyond publications and some of the traditional metrics, we want to know what impact we're having again for our members. Projects, the IRIS scan that we were talking about, that's again, retinal screening, diabetes is a big problem still the biggest cause of blindness across the U.S. We set it up, we were able to screen, we had the total, but we found 280, almost 300 people with retinal disease with no knowledge that hadn't been screened. So these are people coming into the rural clinics who weren't going to the ophthalmologist. We affected that level. So we screen that people. It's working well. I've got the scanner in my clinic. The Partners Fair might not be the largest site in the state, but we've got the scanner and we're still using it 5 years down the road. So it's working well. K-Tech, this one was early on. This was a partnership with the University of Kentucky and their PBRN. Came up with a toolkit to help providers manage patients with opiates and how we prescribe opiates across the state. So they put it in place in 5 sites and increased who's using the controlled substance agreement and who's using more adjunct treatment, coming up with different ways to treat pain. This one was successful and is actually moving into a phase 2 where we're going to try to implement it across 12 sites in Kentucky and West Virginia. So that one's expanding. We've worked with the Medicaid medication-assisted treatment, that's Suboxone therapy for people with opiate disorders. Hub and spoke model where we have more expert centers and then we have people out in the periphery giving the treatment. So we moved up and got 7 new sites. Also helping with the treatment. So that one's coming along really well. One of my partners is working with that, and it's also tied in with BMAP at the project. So, and then we have 2 other projects. Rita and Mary are on, so if you want to take a second to give a rundown on each of the sites for you.
Sure. So basically, I was interested in looking at ways to kind of increase or evaluate the feasibility of universal suicide risk screening in primary care. And so coming to West Virginia 4 years ago from Boston, not knowing the area very well, sort of the first step in that is a study that was under phase 1, where I actually interviewed providers who the PDRN helped recruit. So they were, majority of them were providers that are members of the PBRN, just primary care physicians and PAs and nurses, providers who just did sort of ask them about kind of the feasibility of universal screening, what different practices are, and what interventions would make that more feasible. With the idea of wanting to eventually pilot test a new suicide risk screening tool that's been developed by NIH called the Suicide Screening Questions Screener, and there's actually a toolkit that has a follow-up safety assessment protocol. So I also interviewed the providers and asked them to kind of give feedback about the ASQ tool as well as the safety assessment protocol. And from there, sort of developed actually 2 providers that I interviewed, Dr. Matt Whanger and Marian Maurer, as you can see, both were kind of interested in pilot testing the ASQ screening protocol. So the next phase, which is phase 2, is actually both of those, and we're finishing up that study now. That study was funded through a collaborative grant from the CTSI. We actually, so Dr. Whanger and Dr. Maurer actually pilot tested the ASQ as a universal suicide screening tool. And we used some of the data from the first study to sort of inform the protocol. So they actually did, we decided to do an electronic screening method where the patient got an iPad and, had the consent to the study, but then completed the ASQ screen electronically, and then kind of a brief survey that asked some questions about, what it was like to screen. And then and then the provider, Dr. Maurer, Dr. Weimer, would follow up with those patients that were screened positive. They would flag them electronically, and then they would do the brief suicide safety assessment using the NIH protocol. And so we're collecting the data now, some qualitative and quantitative data, sort of screening rates, before and after screening, as well as detection rates, and then sort of qualitative feedback from the patients about what is like screened, if providers should screen, how should they do it? So it's in the middle of analyzing that at the moment. So, and so far, the data is looking pretty good. We had a high proportion of patients consent to be screened. The majority of them felt like it was feasible, and at least at Valley, the protocol was implemented with very little disruption to primary care clinic flow, which is what a lot of providers were worried about. So,
And I will add in that you also gave an education in fact in phase 1 to the staff kind of across the network on suicide screening. So we set up a webinar, we reached out and taught our staff just the basics of it and where it's important, which was very much appreciated.
Yeah, that was part of sort of the give back to the PBRN. I did an electronic webinar that people, logged in through Zoom or could be by the support.
Really like that.
Yeah, I'm doing the weight management and back pain project with Dr. Stacey, who's in the Department of Nursing. This came about because partly as a specialist, she does spine surgery. She sees a lot of patients referred to her from primary care who probably are not great surgical candidates. And though she likes seeing them, she likes giving them feedback. She wonders if there's a better way to catch patients that need lifestyle modification in the primary care setting before we send them to her. And so in looking at the literature, we found a readiness to change survey that's meant for patients based on weight management. It had been developed in Italy though, and some of the questions, even though it was published in English, some of the questions were not very culturally relevant to our population possibly. And I can sit there and decide myself what that was, but we decided that maybe it was better, it would be a lot better than one person trying to edit that to go and find out what our patients and providers saw in the community. So we were able to get a small grant through the CTSI to go ahead and do some focus groups. We engaged with the PBRN through the process from design through, we went through the protocol review committee. The PBRN helped us with engaging practicing clinicians where we could do these focus groups and also get their feedback. The focus groups, we did them at 4 sites throughout the state, and the PBRN really helped us too with the physical responsibility of doing this because we were compensating them back for their time, and that's something that the researcher was kind of nice to be able to have the PBRN help in doing that. We did 4 focus groups. We tried to get, it's in the community setting. So our goal was to get 2 staff from the clinic, 1 being the clinician, and 3 patients from each clinic that would take part in the focus group. We presented them, we had 2 parts to this. One, we were asking them about facilitators and barriers to healthy lifestyle modifications in their area. The other questions we were asking were related to that survey and how we could adjust that survey. I mean, it was simple stuff that maybe I could identify, things like the word leisure might not have been the best word, or when they transcribed it or translated it from Italy or Italian to English, that might not have been the best word to use in the sentence or for our population. And there was other feedback that was more culturally relevant that we could not have identified as the researchers possibly. So we did that. We did the 4 focus groups, and now we're back at the stage of trying to make the adjustments to that survey, which we will do between now and June, and then we'll send it back out. We sent it out last summer and had patients throughout the state fill out the survey. We're going to send it back out after making the adjustments this summer and hoping to see a better response rate on the survey when we do that.
I know both of you sort of touched on ways that the PBRN has supported your research. What do you think that you've gotten out of it as a researcher?
how to work with the PBRN or?
Yeah, just the partnership as a whole. What do you think on your side, what has been sort of a key factor that you've been able to on the spot?
Everything. You know, I'm using it for right from the protocol development stage. You know, even with this one, before we developed the protocol with this, the PBRN was able to bring together, I think we had 5 clients that we talked to prior to even submitting a protocol to the PBRN. So we used as the early stage investigator, really getting that feedback on the design of the protocol was helpful, not just the clinician, but also the PBRN was able to bring in the research side to us. The recruitment was fantastic and be hard. You know, you might be able to speak better to this. I'm a little bit lucky as a physician that I'm able to call on graduates of our program, graduates of the med school, you know, physicians throughout the state that I interact with throughout other parts of my job. But it was nice to have that PBR and have that formal setup for bringing clinicians on board for taking part.
Yeah, I mean, I think for me, I mean, I couldn't have done either of these projects without the PBRN. You know, I came here knowing nobody. You know, I've been a provider in Boston for 18 years without help coming to West Virginia. So really, I mean, they helped recruit the providers for the first study. You know, they basically did all the recruitment. I mean, I think I recruited one person. So, and, you know, just getting, you know, the support for getting connections through the retreat. Like I attend a retreat every year that I've been here, connecting with physicians. That's how I sort of form those connections to do the second project. So I think that's been the most invaluable thing to me. And then, yeah, and just having the general support around, you know, logistics of things and insight. Yeah, paying them. Paying them, yeah. Yeah.
I have to do that. It's where Stacey has done a lot of work on paying them, but yeah.
So Mary and Tria have really done an amazing job of putting these partnerships together. So it's made it really easy on them. But one of the things that I've noticed that really works out is when we reach out to those providers early on, it makes the recruitment almost seamless because now they understand where the project's coming from. They see their work being put into it. And so then they're asking when they can participate rather than us coming to them and saying, this is something that we want to do. So, you know, the earlier that we can involve them in the project, the better. It just makes the recruitment so much easier. But, you know, there's still some providers that really are not as comfortable giving information up front. So they would rather be waiting in the wing. And when projects come around, we engage them. So I think the consultation part is important because as the network staff, you know sort of where to go for those types of questions. So providers that are ready to answer at a minute's notice and maybe some providers that are not quite as comfortable giving feedback. So just staying in the partnership throughout, both of them have really created a really nice partner with individuals, but as a network as a whole. And so they're our sister children. So
you know, when you engage with the providers up front, literally I just call Stacey's desk and say, hey, I'd like to do this. Who can we talk to? Yeah. You know, but engaging with them up front, kind of every time I'm submitting a proposal to the protocol review committee, it's interesting because a lot of the people that I think will be seeing it have already heard about the project, given me input on the project. I think I've not had any trouble going through it from that standpoint because they've already put their input into it. And so that committee has a lot of people that I might have engaged. I don't know who exactly on the committee reviews it, but it makes that step very less stressful and easier to me.
Yeah. We're up to 12 people, so it doesn't
Is it?
actually
Yeah,
have to be the same ones on everything.
I thought it was like 3 of the 12 or something will review it. So I don't know who's reviewing mine, but I find that input. I know from my side, I can sometimes understand how a project goes through a clinic, just from being a practicing clinician. But I also work at an academic medical center, which is very different from an FQHC. So I could make an assumption on how a project would go through that's not true. So they're able to catch that. And I know from your side, that's probably a big
Oh, yeah, I would say, I've always, I do the same thing. I do consult with Stacey or email her and say, hey, I want to do this. How would this work? And like that feedback, I'll say, this is what might work for this clinic, or these clinics are probably a better fit for this. I mean, that's.
Dr. Sedney would probably say the same things because she's a specialty spine surgeon. And so understanding what's happening in a primary care FQHC, from day one, she's been very clear that she is not bothered by seeing a patient that's not a surgical candidate. And she actually really enjoys giving that feedback. But somebody's traveling sometimes 3 hours to get to her. They're paying a specialty copay to talk to her, and she felt bad that, that side of it, she feels bad about. So how can we improve it from the primary care side? And she was very clear up front saying, I need you because I'm in a different field. And that's been helpful.
So it appears as if, as it started in 2013, that it was started through primary care, and you've got a big emphasis on primary care. What about specialty care? And protocols we submitted using this concept of the practice-based network for specialists who are looking at a particular problem?
So right now, our membership is still made up primarily of primary care. Having said that, though, it depends a little bit about what the topic is, because with most of our membership being federally qualified health centers, they have other specialties that they have to have in their clinic. So most of them will have an OB, most of them will have some type of behavioral health specialist. There's a lot with dentistry. So there are some that are tapped into these sites. That's just, at this point, based on our infrastructure, we haven't done a whole lot to go farther beyond primary care. We've made a lot of connections. So if there's particular researchers that are looking for a topic and we know somebody that's just a really engaged site or clinician, we can make that connection and they can move forward with a project. But for our network itself, we've really just set up for primary care at this time. And so we're able to kind of expand staffing.
Your membership list or your clinical sites here, you've got many with the S's. Are those the other qualified health centers? It's just not labeled as such. Okay.
I was just thinking that's a great question, and it follows really well on what Tria was saying, that, Dr. Sidney is a specialist. So one of the ways to address this in the PBRN would be to identify, because a lot of these rural clinics see everybody. I mean, they're acting as primary care clinics, and they're acting, people are coming to them for all sorts of things. If there's a topic that could, interface between a specialty and primary care, like what Tria just described, whether it be referral, either way, so the specialty having to work with primary care or vice versa, that would fit nicely in with the work of the PBRN, especially if it's in one of these high priority topic areas that the PBRN has already identified. Does that make sense, Phil?
Yeah, and it's more the topic areas and who we're reaching out to, who submits a protocol or anything like that. It isn't important, but who we have on the ground is the primary care clinics in that network. I know at some points during the IRIS program, ophthalmology was thinking about trying to set up an ophthalmology PBRN, connected network of ophthalmologists across the state. But we've got a network of primary care physicians who do their outreaches, so it's come with us different, what fits on that primary care level. But
Seen some specialty primary or specialty PBRNs at different conferences and stuff, but often more national or regional. And I think that's sheer number volume. Retina specialists, we aren't going to have a huge number of retina specialists in West Virginia, but then if you did Appalachia, you could get a bigger number. So that's probably some of it. So if I wanted to go to a specialty one, I'd probably still connect with them, just because they have they've had the connection with, the network, the NAPCRET, North American Primary Care Research Group, PBRN meeting, where you see some of those specialty networks coming to it, or HRSA that has some documentation of different primary care networks. I'd probably go to Stacey. Where do I go?
sure. Name church.
HRQ, sorry, not HRSA, HRQ.
But they started it as one of their methods of expanding research in primary care.
Yes.
And so they've been driving force with a lot of the PBRNs across. So I think that's really
And while you look at West Virginia, you mentioned topics you might reach out and go beyond the boundaries of West Virginia just to
Yeah,
collaborate
so
with
we
those
have
people.
we've had a funded project with Kentucky's ambulatory network, so that's their PBRN. And so that's out of the University of Kentucky. And then we've had a partnership with a Pennsylvania group as well, the Lehigh Valley PBRN. And so that one we've submitted with. We haven't actively worked with them yet. We're hoping to soon. And we've also made connections with one of the Quebec PBRNs as well, because their population still falls into the Appalachian region. And so they had some interest in collaborating with us as well, which was an interesting conversation, because I had not realized that. I think we're really unique in the fact that we're statewide. Many of the PBRNs are very regional or sometimes even city-based, and so it's something very highly dense populations that are spread out a little bit more. And so I think for a while that wasn't sort of the model that the PBRN generally used. But we knew that with our infrastructure, that was going to be the best way to set it up. And actually, I think we've overcome a lot of barriers to move forward and make it a success. So I think you're starting to see more rural populations reach out to a PBRN.
And ours is also, most of them are either F2HC or academic, so we're trying to bridge that, and we're trying to get some private practitioners involved too.
Does anyone have any other questions? Even on the phone, you can ask a question if you like.
When you talk about funding, they're still thinking about what questions they're going to ask. What's the average amount of funding that might be available for a project in order to have whatever clerical, statistical support, etc.
So the funding,
within a high priority project.
so the funding is all outside of the PBRN, so we're helping people get funding in different locations.
Okay.
A lot of PBRN type projects tend to get the funding from AHRQ, since they are the ones that really have initiated the PBRN process. We have a lot of funding that comes out of CTSI, and then we kind of opened it up to some larger entities. So that we just got Corey, that was our first try at this. We've done a couple of NIH submissions, and we've had some other kind of foundational grants too. So it varies a good deal on sort of what the project is really looking at and who's doing the submission. So one of the things that we've done as a network is really try to enhance the clinicians that are also conducting their own research, or at least co-PIing a project, or really stepping up to a leadership role. And so they are going to be looking more at the foundational grants because their research background is not as strong as some of the folks that would be here at the institution or one of the other medical institutions. So really try to fit whatever funding seems to be appropriate. So that's why we looked at several different ways. So we've done everything from foundation all the way up to NIH before.
We've tried to drive people to have data collection on their end, not to ask the sites to do the data collection. So as we try to get site participation, we don't try to find funding to get out to the site and take the data and stuff. We would rather have that up for people stuff on their own that way.
Sure.
I've always compensated the site for time. It's interesting, you know, I'll always put that in there because they should be compensated for their time. But I've had one connection I've made specifically through the PBRN. She's a family physician, but I didn't know her until the PBRN. She doesn't care if they get funding or not. It's their health system. She never seems to, you know.
Sure.
But it's there. It's been more that collaboration and just getting to do some research with someone that's been the interest in her. So.
Any other questions? Thank you. I appreciate the chance to talk.